Hi there guys, and welcome to today's live stream. We're going to be talking all about hyperlordosis being a cause for lower back pain, help you guys understand it. You'll see there's some drawings on the board behind me. We've got some good slides to go through with you guys today, so hopefully you're going to find it really interesting. And remember, if you do find these live streams useful, then please do consider commenting, add your questions to the bottom because we always do Q&A at the end, and please do share those with anyone that might also find these live streams useful. And with that out of the way, let's get started. So guys, today we're going to be talking all about hyperlordosis. I've got a sort of a good bit of detail on this today, so if you've got any questions on this or some of the nuanced differences, we're going to go sort of very basic on this on the board up here, a little bit more detail down here. We're going to cover the variations of hyperlordosis. Some of it is actually technically going to be a hyperlordosis, some of it is not. And that's really, really important when prescribing the right exercises for this. I actually touched briefly, I think it was yesterday, on spondylolisthesis and doing posterior pelvic tucks, and you really need to understand whether or not you actually have hyperlordosis or not, if you're going to then start doing exercises to change that. I'll go through how you identify this or how we identify it in clinic. Some considerations. A lot of people will get hyperlordosis diagnosed from someone just running their hand down their back and saying, oh, it feels a little bit too curved here. And you'll understand why by the end of this video that is a very bad idea. It's really oversimplistic would be the word. And then also, what are you going to do to fix it? How can we map this issue, and how can we better understand it? I'll also help you guys understand how we actually measure it when you come into the clinic. So first and foremost, variations. We'll take it over to the board to start with, and we've got the variations here. Now I want to start off by helping you guys understand this, because a lot of people get these things are commented, and if you've ever had, I've mentioned this before, if you've ever had a diagnosis of lordosis, please disregard what is being said, because we should all have a lordosis. It's whether it's hyper, meaning too much curve, or hypo, meaning too flat. And lordosis refers to the curve from L1 down to L5. The sacrum actually is a kyphotic, it's forward bending. You can see that it's fixed, it's not ever going to change. But the lordosis refers to the lumbar spine exclusively. And remember that, because later on it'll become a little bit more evident where we can make mistakes in identifying a lordosis. And the thing we need to be mindful of is with a lordosis, in the lumbar spine itself, you're going to get, when we have too much lordosis, we're going to get more pressure on the back of the joints here, what's called the facet joints. And you think of this like a spring. It increases lordosis under load and unloads. So if we're already, say, 50% increased in our lordosis, we don't have much more spring in that lumbar spine before we start jamming these facet joints together, which can create a little bit of facet arthrosis and that sort of thing. If we've got not enough curve, then we have other issues which we've touched on in a lot of cases, or in a lot of the live streams, the problems with reduced lordosis. And from experience in the clinic, bear in mind, whenever we're seeing patients, the overwhelming majority over the years, my entire clinical practice, has more or less always, the patient has had x-rays to go alongside their presentation. So you do see these things time and time again. And I will say to you, it's, in my opinion, less common for someone to have a hyperlordosis, i.e. too much curve. And this is also closely related to anterior pelvic tilt, as I'll get into. Now, the fundamental understanding I want you guys to understand first is this. This is the normal. Now, obviously, it's the other way around, so it's like that there. This is the sacrum, this little triangle one. That's the orange sacrum on here. That is fused bone. And then we've got this nice line that represents the lumbar curve. And this is almost like a little wheel. We've got the hip flexors that run down the front, and those pull and stick your bum out, so you go like that, and that increases the curve. And then you've got the hamstrings at the back, and those pull under to flatten the curve. And both of these can be tight, and in either scenario. So if we do have, what we see here is an abnormal, or is a normal abnormality in terms of hyperlordosis. This means that the curve is normally too much. It's changed in a normal way. So the curve is too much, the bum is sticking out, and we've got what's called anterior pelvic tilt. That's where the whole thing goes like that. And now we have too much curve through here. And then we can undo it and we reduce the curve. This is I've put normal abnormality because if you actually have hyperlordosis, there are a number of challenges here. I've already mentioned one of them where we can jam onto the facet joints because we've already pulled down too much. But also, we're going to get the hip flexors getting too tight and shortened. The hamstrings are going to be pulled and elongated, trying to hold on as this attachment site down here moves further away from the back of the knee. And that quite often will result in tight hamstrings. So the problem with this is that people with an increased lordosis will also report tight hamstrings, but the hamstrings are tight and too long. So really, in a lot of these cases, we need to strengthen those hamstrings up so they can start to pull everything back round and decrease the stress on that lumbar spine. The other thing that's important to note with the actual proper hyperlordosis is you do have, when we see patients with spondylolisthesis, they're more likely in a lot of cases to have a hyperlordosis. The main reason for that is that you have the L5 vertebra on the top of here, and we have gravity, and that's creating a shearing force here, and that increases the likelihood of repetitive stress and strain on that L5 vertebra, which over time causes it to slip forwards sometimes. It is much less common, but those of you that do have a spondylolisthesis, it is a little bit more common in the early days to have this sort of hyperlordosis. It's just the way in which the mechanics start to put repetitive day in, day out stress on that section of the lumbar spine. What you also commonly get is a co-occurrence of disc injury. So we have an L5-S1 disc injury where there's a disc bulge there as well. Now, a little word to the wise, this is just from clinical experience. A lot of times you're going to go to your GP and they say you don't need to get an X-ray, you need to get an MRI. And the problem with an MRI is, and we've seen this a number of times, more than you'd care to like, is that someone with this hyperlordosis situation, when they lie down, the curve will flatten a little bit. And what happens is, with gravity, this vertebra maybe slides back a little bit and doesn't show its anterior-listhesis. It just shows there's a disc bulge. And actually, when you stand that person up, you can see that there's actually that little slip forwards under load. And that means that a simple disc problem is actually not as simple. It's got a little bit more of complexity to the situation. And therefore, you need to know about that if you're going to treat it effectively. Just a little word, sort of tangent there. If you guys have any questions on that particular part, please do put them in the comments, and I'm happy to sort of elaborate on that particular topic. Now, the next one is the abnormal curve. And this is an issue. And I'll get down to how we measure it down the bottom here so you guys will understand how this can happen. But in this person's spine, they're going to have a very straight spine and they have a pivot at the bottom down here. And this is an abnormal movement pattern. It's very difficult. If I said to any of you guys now, can you please hyperextend your L5-S1 joint, you're probably looking at the camera going, what on earth are you talking about? It's very difficult because we don't have the ability to move this joint only. Like you can move your elbow only without bending your wrist or bending your or moving your shoulder. You can't do that in the spine. So it's really at the whim of how the whole thing wants to move. It's generally a traumatic occurrence that's caused this issue to take place. And that will create the illusion sometimes of a hyperlordosis, too much curve in the lower back, because there's a hyperextension here and a flat lumbar spine. Quite often in this case, you might also look like you're swaying back. So that posture you would adopt when you were carrying a heavy box or pregnant, you lean backwards to kind of counterbalance the weight, and it moves inappropriately down here, and that can also create the illusion of a hyperlordosis. Now, how do we get into actually identifying these things? In clinic, we use standing up x-rays. So this really, in my opinion, is the gold standard because a physical examination is just so inaccurate. Now, these drawings down the bottom here are up to my usual good standard of artistic competence, but you get the point. We've got the 5 lumbar vertebra and the sacrum at the very bottom down here, and we've got the skin hanging over the top. And these two variations, I will lift the board up in a second when I get onto the second image, but might both be visually look like there's too much curve in the lower back. And the exact opposite is true. Maybe later on, later on this week or over the next few weeks, we'll do on a hypolordosis. But what we do when we're measuring these curves, if I just get a darker pen out, is we have the L1 vertebra up here and we have the L5 vertebra up here. When we're measuring the lumbar curve, we are not measuring down to the sacrum. That's irrelevant for the moment. We do other measurements on the sacrum, but we're looking at this here. And we take a line along the back here, and we take a line along the back here, and then we measure this angle. and that angle should be 40 degrees. There are individual angles along here that should also be correct, so we go into a lot of detail, but just for the simplicity, this angle then, or this angle, should be 40 degrees. Now if it's 45, if it's 50, if it's 60 degrees, then we've got an increasing curve, and that is a objective hyperlordosis. You've measured the lordosis and it's significantly increased, and then we can work on taking steps, incorporating this stuff, these muscle balances, to reduce that curve that's going through the lumbar spine. And also we understand how that patient, how you may have different muscle imbalances and different stress and strain on your body, so treatment can be tailored to those sorts of things, or rehab. If you're in the membership site, you can adjust some of those exercises to make them a little bit more specific to a hyperlordosis. But as I'll get on to later on, we need to map what our lordosis looks like if we're going to be successful in treating it. Now, this might be an increased curve, for argument's sake. Let's just say it's 50. So it's around about a 25% increase in the curve. We normally measure it as minus because it bends backwards. Now, one of the considerations I want to get to before we go into the abnormal variation is soft tissue. If we've got particularly large glute development, or we've got fat tissue lay down there, all of these different things can really have an impact on whether or not we can see whether or not what is actually there is being displayed on the surface. And that's a real issue with this. Sometimes, me for example, I've got quite a lot of glute development because of some of the sports I did when I was younger, and therefore it looks like I have a hyperlordosis and I do not. So it's quite important to know the limitations, and it's something that, from the benefit of seeing lots of images over the years, I can understand there are significant limitations in what you can see in a patient and feel on a patient, and sometimes those limitations aren't understood by all practitioners, so they make these inferences without actually understanding the limitations of what can be inferred on a physical examination. So if you've been diagnosed with it in the past and it hasn't been properly measured and quantified, you do want to be cautiously careful, because there are other things which I won't get into, such as the way in which your pelvis is built, the relationship between where the hip is compared to the sacrum, and other things which can complicate this measurement. But this isn't a CPD course, so for other professionals, so I'm not going to go into those details there, but there are a few nuanced exceptions that you need to be aware of. Now, when we get into this one here, I've drawn this deliberately, very badly actually, but hopefully you guys can see that yet there. So we've got the same thing. It looks like there's a little bit of curve down here because of the way in which the skin's hanging over it. But we've got L1 up here, and we draw a line out, and we've got L5, and this is maybe like 10 degrees, okay? Very, very low curve. Okay, we'll call that 10. So that's a 75% reduction there from what it should be. But what we see down here is that there is a very steep angle at the sacrum. This is called this is a hyperextension that I was talking about. Whereas here we have a lesser angle. If we measure that, it's a much increased angle down here, which creates the illusion. It's the interaction between your lower back and your sacrum that is hyper. It's too much compared to the actual lordosis itself. And in these patients, when they do things like posterior pelvic tucks, which would be okay for this person to do to reduce the lordosis, they really do get made a lot worse because the lumbar curve is often reduced substantially. So this illusion is a double whammy for being worse, and that's where the abnormal comes in. This is an abnormal misalignment, if you will, and normally is associated with some sort of injury that's happened in the past. It might have been a backward bending accident in some way that's caused excessive strain to focus on one particular joint. So it's not as simple. Those are just two variations, but it's not as simple as saying, oh, the curve's too much because it feels like there's a little bit too much of a dip here. There are nuanced differences, and the reason I wanted to go through this in today's live stream was to just make you guys aware of that, understanding the limitations that someone can that are there if you've only had a physical examination. And this is why we're cautious, especially in the Back in Shape membership site, with making too much in the way of specific, make that change to reduce your lordosis, or make this change to increase your lordosis, because we don't want to fiddle with things unless you've had a proper evaluation and objectively measured it. Now, if you are going to get that done, then it's very, very easy. You get the measurements done, you objectively measure what these angles are, and then you can say, right, we need to do X, Y, and Z. Maybe we need to do some posterior pelvic tucks, tucking the bum under to reduce what's called the sacral base, the slope at that the sacrum has, which is what I referred to up here, this line here. We can do some posterior pelvic tucks to reduce that. We can also work on our hip flexors and hip extensors. So that means stretching out of the hip flexors correctly. When we do incorrect hip flexor stretching, we just arch the back too much and it doesn't work very well. But by engaging our core correctly to hold the spine in and then just moving the hip, we can really get a nice stretch through the front of the hips to stretch those hip flexors out. And then a concerted effort to start to strengthen up those hamstrings and build in a little bit of support to help tuck this thing backwards so we can effectively work on reducing that lordosis for the long term. And we don't want to be overzealous here either. We want to be balanced, but we want to be, we don't want to be balanced. We want to be effective, but we don't want to go too far the other way, because having a hyperlordosis is what I would argue is much more common, because it's easier to get into that position, the way in which we use our bodies on a daily basis now, than it is to get a hyperlordosis. But you just want to consider these things before you make any changes to your body. That's quite important. I think just before we get into Q&A, I'll just round this one off by just showing you guys a little bit of an anatomy one, a drawing that I pulled off YouTube here. You can actually see it made out with much better artistic work here. The image on the left-hand side, ignore the crosses and ticks and things, but essentially you can see those glutes, hamstrings on the back of the image on the left-hand side being balanced with the core muscles on the front and holding that pelvis in a neutral position. Whereas the one on the other side, commonly, again, this is associated with the hyperlordosis. They're talking more about anterior pelvic tilt here, but you can't, it's very difficult to get one without the other. You can see those hip flexors are pulling the pelvis forwards, pulling it round like on this drawing up here that you can't see now, and really increasing that curve. So that's sort of the muscular diagram for you guys, but understanding the structure underneath is really, really important. So with that said, we'll go straight into Q&A.
Okay, awesome. Alex on YouTube asked us the other day about if you do have a spondylolisthesis, is the towel exercise appropriate?
So yeah, the question was about spondylolisthesis. If you've got one of these, is the towel exercise appropriate? And it's something you want to be much, much more careful about. If you've not got an anterior pelvic tilt, a hyperlordosis, and you've got the spondylolisthesis, maybe it's much more of a degenerative situation, then it may well be worthwhile attempting the towel exercise very, very tentatively, just lying on your back for a moment or two to see how it feels, get off and reevaluate. The reason I say that is sometimes you can reduce the curve quite substantially with a spondylolisthesis. The person gets into a very flat spine, and it's not actually the spondylolisthesis segment. It's not actually this one that's in trouble. It's the one above, because quite often these spondylolisthesis, they get that's such a mouthful. They can get quite degenerative, and then they kind of fixate. They get almost fused with soft tissue and kind of grit in there. And it's the ones above that are still quote unquote healthy that are being overworked. So sometimes the towel is appropriate, although we would recommend that in clinic with close observation. So please bear that in mind if you are going to try it. But at the end of the day, trying these things very, very tentatively and cautiously, if you are in this boat of having these spondylolisthesis, is something that may be worth considering.
I think that actually also answers Ollie's question. Are there any alterations someone with this would have to make to exercise with the towel or the dead bugs? I don't know if there's
anyone with hyperlordosis. So yeah, if you've got hyperlordosis and you're doing, say, the dead bugs, for example, then you do definitely want to, well, two things. First and foremost, you do want to do a slight posterior pelvic tuck. You could probably get away with a slightly more aggressive one. I know we did that live stream with Lawrence a while ago, where we spoke about, where he mentioned about doing that posterior pelvic tuck to lock the pelvis, lock the back against the floor to do the dead bugs, which is something we don't normally advise. But if you do have a hyperlordosis, a measured hyperlordosis, not I think I have too much, if you have a measured hyperlordosis, then actually that would be a sensible move, number one. Number two, after you finish the dead exercises like the dead bugs, you must get in and get those hip flexor stretches done as well. That's very, very important.
That's interesting. Okay, Joe has asked, would you recommend stretching the hip flexors more than the hamstrings when you have anterior pelvic tilt?
Yes, that's exactly what we recommend. So when we go through, for example, the Back in Shape membership site, there's those stretches which are balanced. It's dealing with the majority of people which will have a degree of normal structure. Maybe there's some slight variation one way or the other, but it's fundamentally quite normal, and therefore it's not necessary to focus. But what we normally say is when we have patients in clinic where we objectively have measured they've got too much curve, then it will be a case of you should be doing around about a 5-minute stretch on each muscle consistently to allow them to really stretch out and open out on those hip flexors. And at the same time, you want to have a little bit more focus on exercises that enhance the strength and integrity of the hamstrings simultaneously.
Okay, great question here from Karen. She said, if you're having x-rays instead of an MRI for the spondylo, are you going to see the disc bulge if there is one present?
Yeah, so a lot of people ask this question with regards to disc bulges. Let me draw it out on the board for you guys, because they say, oh, look, an X-ray doesn't show the bone, only shows the bones, it doesn't show the soft tissues, and there's a few answers to that. Number one, you have to say, well, if you're sending someone for a MRI, you kind of already know they've got a disc bulge anyway, and it's a case of how far bulged has it gone, and therefore, well, is it actually that much? It's not how useful is it in treating that patient in a better way. If you're going to consider surgical interventions, then yes, it's helpful because they can see where they want to chop out. But if you're not considering surgical interventions, and quite often patients say categorically, I don't want to do that, and maybe they're getting better with treatment, so they want to continue that, but just have a more informed treatment approach, then X-rays are much, much more useful. But essentially, this is my, again, expert drawing of a disc. There's a disc in the middle here. There's a certain space between the bones that the disc should have. So therefore, if that space is down here, where has all this material gone? Well, it must have gone to the sides. So although on X-rays you do not see the disc material itself, you can see that if the gap between the two bones has reduced compared to what it should be, and bear in mind these discs at the bottom of the lumbar spine, the L5S1 and the L45 disc, and sometimes they're not referred to like that, but 4-5, that's the disc in between 4-5, and 5S1 is this disc here. If the gap should be biggest at those junctions, and if it's smaller, then you can infer that there will be a disc bulge there because the disc material has to go somewhere when the gap between these two bones decreases. So I'd rather argue that although you don't necessarily see the disc has bulged, you see that it must have bulged because of the displacement of the bone. And also, from doing that standing X-ray, you now have extra information, a better understanding of this patient's biomechanics, so that your treatment protocols, from a non-invasive point of view, can be more tailored to that individual's biomechanics. And that's why, in my opinion, a lot of the standard protocols are going through, do physio if that didn't work, do an MRI if that didn't work, then move on like that. They just don't tend to get the results for the patients because you're just saying, oh, well, there's a disc bulge there. And you go back to the physio or whoever, and that's not an attack on physios, but you go back to the practitioner and they don't do anything different. Well, what was the point in spending the £200, £300, £400, £500, £700 on the MRI if it's not made any difference to your treatment protocols? So that's quite important. Why are you getting the MRI? Now, sometimes you're just getting the MRI because you as a patient feel more comfortable if you've seen that disc bulge and you understand it and you can visualize it. And that is perfectly valid. But you need to understand, what are you trying to get out of this particular image? Are you trying to get a better treatment outcome, or are you trying to just understand what a disc bulge looks like? And that's quite important. And some people will say, do you know what, I want both. I want an MRI so I can see the disc, and I want to get X-rays done so I can have a better treatment. That's your personal choice, but you should have that discussed with you, in my opinion, by the practitioner. And obviously remember, MRIs are more useful if you're going to go down the surgical route. That's the reason.
Comes down to finances.
Yeah, and it comes down to finances. Yeah, if you've got insurance that'll cover both, then fantastic. But you have to weigh those things up.
Yeah, I've got a question.
Yeah.
You might not want to go into detail now. It might be one that we cover as a whole life. Injections.
Injections.
Are they helpful?
So like steroid injections,
what are they
epidurals.
actually doing?
Okay, so there's quite a lot of research on injections in general, particularly corticosteroid injections. And if you look at a lot of the more forward-thinking clinics around where we are in London, you'll see that people are moving away from steroid injections towards things like PRP, stem cells, and those sorts of things, because the outcome of the injection is, in those cases, might be to improve the healing of the soft tissues that are there. Now, research on steroid injections goes back years, and there's a lot of it, particularly in supraspinatus in the shoulder and Achilles tendon research. And what they find is there's a short window, so around about 2 weeks, of decreased tensile strength of the soft tissues, i.e. they're more, and then as a consequence, they're more likely for those soft tissues to rupture. So that's not a particularly good thing if you've got a weak tendon that's inflamed already, and you get what's called tissue necrosis. It's basically a bad response to the steroid injection temporarily, because it's essentially something that shouldn't be there, and it's creating an inappropriate response in the soft tissues to numb the pain. So that's the first thing. That's what it's doing in your body. Now, sometimes they will use injections for, well, two different purposes. Number one is diagnostically. So it'll normally be your orthopedic surgeon or neurologist might be doing an injection to actually understand, is this bit where the pain is coming from? Because they do the injection, the pain disappears. They can assume that, okay, well, it was that disc that's causing you the pain. If it doesn't go away after a little while, then maybe we should actually consider removing the disc through surgical intervention, because as soon as we numbed that area, the pain went away. So that's an understanding, and that's often not transmitted to the patient very well, and they aren't aware that that's even a thing that's done. So that's quite important. The next one is quite commonly they you come in with a disc injury and they say, I went for facet joint injections. Well, why did you go for facet joint injections? Because the facet joint is over here where they've injected, and the disc is round the front here. So that's a peculiar one, which I don't quite understand, but that's the way it is. The other thing to bear in mind is you can have injections under image guidance or without. And I've already been through the poor ability of us to really understand where exactly we are in the body, in spite of, yes, bony markers, etc. But there are anatomical variants from person to person. And therefore, just feeling your way and poking the needle in to try and deliver the injections, I think, is quite bad. And if you are going to do any injections, they really should be image guided, so that you're putting the stuff in the right place. That's quite important. We shouldn't just be willy-nilly poking stuff into the back. But steroid injections fundamentally are there for a local pain-reducing response. And it's really important for you to bear in mind that we don't do injections in the clinic. That's not what we do. But a basic understanding of what is being done there, it's there to reduce the pain, and it's not there to fix the problem. And that's the really, really important part that you guys need to understand around the side of injections. They're not doing that. Now, stem cells, PRP, different kettle of fish, much more interesting, much more positive treatments, and you really want to discuss those. But because they're newer tech, there'll be some older practitioners, doctors that aren't keen on those mechanisms. And I think, from my experience, having spoken to numerous ones, some that are into it and some that aren't into it, it's just clear that as a medical doctor, if you're set in your ways, you've been doing certain things for a number of years, you're not really keen to innovate or change. You tend to disregard any of the newer technologies, and that is a little bit mean for me to say that, but it's the truth. Why are certain doctors adopting them and others aren't? I think it's mostly out of laziness more than anything else, because that's the way it is.
Okay, well, maybe we should do a full one on injections and different treatments.
Yeah, if you guys would find sort of a full live stream on injections, etc., useful, then please do put that in the comments below. We can go through that and talk about it in a little bit more detail. It's important you guys recognize that obviously we don't do injections in the clinic, but there's that baseline understanding of what they're doing, and hopefully if we can explain it in a little bit more layman's terms, if it's something that you are considering, you can then have a more informed discussion with your doctor, because quite often patients, and I get this, certain types of patients, when they go into the office and they say, look, I'm seeing my MSK specialist or my orthopedic surgeon or whatever it is, they don't feel confident enough to ask the correct questions to inform them. And it's really important that even if we do this video, you guys feel like you've got a few questions to ask to help you better understand. And they might say, do you know what? You should have that steroid injection, and then you should follow up and make sure you use the next 2 or 3 weeks to really get ahead with your rehab, which is what normally should be prescribed. That's what they'll normally try and do. A good one will say, look, you've got to do your rehab, but at least you'll have the better understanding of what questions you can ask your practitioner when you're in the office, considering these sorts of options. And the same thing for surgical interventions. You should know what questions to ask so that you don't end up leaving the office saying, oh, I should have asked all these different questions. Even if you don't feel comfortable doing that, you should ask them anyway, because it's really important that you understand what someone is going to do to your body. And we always encourage questions in the clinic. It makes it more fun anyway, because you help the person, you help you guys understand what your body's about to go through, maybe from a treatment point of view. And it also helps us figure out some of the things that maybe are misunderstood, it might be holding back your recovery. So that's really important. And these surgeon guys and these orthopedic surgeons and neurosurgeons, they're clever people. They know their stuff. So why not ask them questions to help you better understand what your body's going to go through?
Yeah, that's interesting. I feel like maybe sometimes people want the injection or want surgery because they think it'll be a quick fix and they don't need to do the rehab, but what they don't know is there's always
every time
to do.
I remember we had someone with a hip who wanted to get a hip. We were treating the back pain. Back pain was fine, but there was this lingering hip problem, and he wanted to get a hip injection. I said, look, if you're going to do that, you have to do the rehab. There's no non-negotiable. I know the guy that did the injection, and he said the same thing, and he didn't do the rehab. And he was pain-free for a couple of weeks, and then it came back. Yeah. You have to do the work. These steroid injections, often people run to them in the last, as a last-ditch hope to get rid of pain, and aren't considering the entire problem in of itself. And that's really, please don't make that mistake, because they're expensive, and you want to get better ultimately. So
we've covered it in quite a bit of detail already, but we
will do a proper one on these. We'll get some more prep ready and help you guys out. So hopefully you found this video helpful. We've gone off on a bit of a tangent towards the end of that one, but that's what the Q&A is there for. Hopefully you guys find it helpful. Please do get involved. Have your comments in the comment section below. If you're watching this after we've gone live, which you probably are if you've gotten this far, then please do put comments down, because we will answer those in the next live stream or any future live streams. And remember, please consider subscribing, liking and sharing this video with someone else that can benefit. We do these live streams every single weekday. We'll put the topic out in advance as well, so you guys can come in, watch the topic or whatever it's on, and then ask your questions so you can get some help, especially in current circumstances, current times. It really makes a difference being able to get a little bit more guidance and dealing with back pain earlier, rather than leaving it for the next 3, 6, maybe even 12 months until lockdown ends, and then getting the help. Proactive steps forward can really help you get better faster. So until then, have a great weekend, guys. We'll see you on Monday again with another live stream.